Dr. James, you are really a champion of quality globally. What message do you have for governance leaders of hospitals and healthcare systems?
The most important thing that a leader needs to understand is that it's systems, not errors. We've done careful research on this topic. About 95% of our opportunity to improve comes at the level of making it easy to do it right. You don't need to rebuild people's morals, their commitment, their work ethic. They're as dedicated to patients as we are. The trouble is when you mix complex systems with earnest, hardworking, smart people, they will fail. Now, having said that, about 5% of the time it really is error. About 5% of the time it really is personal excellence. I wouldn't want you to lay that one off. It's still critically important. But as a leader, most of the time it's you, not them. It's the system and the context and the environment that you create for them.
Fantastic. So governance leaders really need to invest in systems?
My job is to make it easy to do it right. In a very real sense, you know how people get into ruts? For Intermountain, I create ruts. The difference is my ruts happen to represent evidence-based best practice. The joke is that when you're in one of Intermountain's ruts, it's not really a rut, it's the groove. You're in the groove, you see. Now, I understand that people need to vary from that common approach based upon individual patient needs. We build that into our systems. But I build the context. I make it easy to do it right.
We're fighting a war on healthcare harm, and we really need to focus on systems and harm and not errors in the way that you've described it to us. Is chasing zero a reality? Should that be the goal, to chase zero harm?
The only acceptable goal is zero harm. Now, will we be able to achieve that in our lifetime? Maybe not, but we don't know how close we can come. We have to find out how close we can come. In some areas, I predict we will achieve zero. In many others, we may not achieve that ultimate end result, but we'll make real progress in that direction. We measure our successes in human lives. It doesn't matter until it translates into a real individual, a real human being. Not just live or die, but relieving pain and suffering, improving a person's own experience of life along the way. You know, it's the funniest thing. I'm regarded a bit as a theoretician of clinical quality improvement. None of it matters until you know if it works. None of it matters until it translates into real people.
What is your take on hospital-acquired or healthcare-acquired infections?
The only reasonable goal is zero. The goal is a star on the horizon by which we steer. A goal is a way of pulling a team together and move them all in the same direction. One of my favorite quotes, an old Yiddish proverb, better has no limit. We may not get to zero this time, but we'll make real progress. And that real progress translates into real lives. The only goal is zero, and then to see how far we can move in that direction.
Many organizations now are measuring the days since they've either harmed a patient or the days since they've had a type of infection. Is that a good way to keep people focusing on zero?
A good way to keep focusing on zero is measuring how long it's been since your last infection or since your last event, especially when they become very, very rare. It's one of the only effective ways we have to measure. Speaking as a statistician, it massively increases my effective sample size. It means that I can tell if I'm making progress while I'm waiting for the next event. From a statistical standpoint, it's ideal. It effectively expands your sample size so that you can get more information more quickly to drive real change. It works at a whole deeper level. It's effective down at the front line, where real clinicians are caring for real patients and they're tracking those days since last, you see, trying to avoid the next one coming ahead.
Brent, we talk about the 4 A's of innovation adoption: awareness, accountability, ability, and action. Do you think that our leaders today, leading hospitals at the governance and the administrative CEO level, really are aware of the performance gaps that exist today?
Most leaders in most hospital systems are not aware. The reason is they don't have good measurement systems. You don't know what you don't know to some degree. In fact, one of the key things we did at Intermountain was to build out those data systems so we had a true transparent picture of our actual performance. Frankly, it was a little bit appalling in some circumstances. Well, there's the energy for action right there. There's where you have the wake-up call that tells you it's time to move. When you become convinced that you could be better, that's the first step to improvement.
Accountability. How important is personal accountability to make change?
Accountability is critical. The trick is that most real accountability is internal. It's based around our professional values, the fact that we really want to do well for the people that we serve. Tied directly to accountability is this idea of transparency. Transparency, we studied it twice at the Institute of Medicine. In each case, it turned out to be not just that initial decision to choose a physician or a hospital. It was a series of clinical decisions, and at each point in the chain, understanding the options and where they led. We're back to describing systems again. We've discovered that when we give our physicians and nurses true transparency, so they see the long-term effects of their actions, that's where true accountability lies. If not at an individual level, certainly at an organizational level. That's when we see the gap and we start to move.
You can be aware of your performance gaps. You can make people accountable for them, but if they're not able, if they're not empowered or have the resources to make the change, it's a major barrier. Is that a fair statement, and what would you add to that?
You're entirely correct when you say that ability to drive change is perhaps the essential element. Again, people are trapped in the context that we as leaders create. They have very little control over it. I've learned over the years that they're as dedicated to patients as I am, they're as smart as I am, they're as hardworking as I am. But I control the context. I control the systems, you see. We can create ability within an organization by the way that we structure a system. We don't just set the vision, but we supply the tools. We supply the direction, that shared accountability of the direction where we're trying to move and how fast we're progressing toward it and how much each is contributing along the way. In the end, it's all leadership, isn't it? This idea of ability and the resources that we align within a system to make dedicated, right-thinking, patient-focused people able to do it right.
You can be aware of your performance gaps, you can make people accountable, you can make them able, but in the end, it's all about action. And I know that in our conversations that you've said in the end, nothing matters until you get the result. Tell us about the line of sight actions that together can have real transformational change.
We know it worked when it has impact in a real patient's life. You know, I learned quality improvement theory from a fellow named W. Edwards Deming. The way that Dr. Deming used to describe it is something he called fundamental knowledge. It's the fact that theory is different from reality. Theory is an abstraction in nearly every case. He built his whole approach around that idea of fundamental knowledge. To really act, you have to know it at the front line. You have to experience it almost every day. It's the same principle. This idea of action. You can have the most wonderful theory in the world. You can have esoteric, groundbreaking discussion at a board meeting. Until that translates into real patient lives, who cares, frankly? What difference did it make? You see, we count our successes in lives, in patients' lives, in fewer deaths, in better patient outcomes, in less suffering, in a better community. In the end, that's all that counts.
And leadership is absolutely critical. We talk about the three spheres of leadership, practices, and technologies. Engaged leaders, practices, safe practices that have predictable results, and then the technologies that enable them. And that you need the first two before you have the third, and the first is critically important. How vital is specific engaged leadership at transforming healthcare?
Leadership is the central element of success. You see, we create the systems within which others work. We have massive control over those systems. They have very low control. That context, in large part, determines their actions, the range of choices, the work they have to do to reach a particular end. When we see it at that level, we realize that, well, we're key to their success. And our job is to make them successful. At Intermountain, my primary role is to make it easy to do it right. The people I work with, again, they're as smart as I am. They're as dedicated to patients as I am. They're as hardworking as I am. The difference is that I control the context of the success.
What should leaders know about the most common events that we see, the hierarchy of events and frequency?
There's a very strong hierarchy of prioritization to the sources of injuries in a hospital. Number one is always adverse drug events. That's where you have a drug-drug interaction or an allergic reaction to a particular medication, or most commonly a drug overdose. We give you too much of that thing and it causes a complication. Those by themselves are about 50% of all hospital-related events in our best measurement systems. Number two, they're called hospital-acquired infections. That's where you come into the hospital and as part of your care you're exposed to a bacterium usually that causes an infection within your body. Primary within that are called postoperative deep wound infections. So we do surgery on you and the surgical wound becomes infected and often penetrates into the interior of your body as part of that. Number three, bed sores, pressure injuries is what we call them, where the skin is damaged by pressure. It forces the blood out and then the tissue around it dies and erodes in through the skin to underlying organ structures very often. You know, we did some careful research at Intermountain some years ago. We discovered that for patients hospitalized at least 5 days, 23% of them developed a new pressure injury. Now, most of those pressure injuries are relatively mild. A stage one just means you get something called capillary filling defects, where the small vessels in the surface of the skin stop moving blood because of the pressure. It's the first step, though, toward getting a full ulcer in your skin, and then, of course, it goes down from there. And number four, mechanical device failures. The main work on this was done by Dr. Scott Evans at LDS Hospital. That would be where the tubing falls off a ventilator, or an IV pump that's moving IV fluids into your body fails, puts too much in, or stops working at all in some way. That's the fourth most common cause of patient injury, though. Number five, we call them complications of central and peripheral venous lines. So it's just an IV line going into your body, or the big ones that we put into the large veins in your central body and usually thread them in towards your heart in the venous system. Well, now when I say complications of peripheral and venous lines, it requires active damage. So it's not just that the IV fell out. It might be, for example, that the IV at the point of insertion leaked fluid into the surrounding tissue and that fluid damaged the tissue around it. So we'd call that infiltration with local tissue damage, for example. Now, there are other categories of injury that go beyond this. Certain sorts of injuries that happen primarily in surgery. But when it comes to the main big list, I think that you manage to handle those five, you're a long way toward making care much, much safer.
So it's fair to say that a governance leadership team, an administrative leadership team, that the medical leaders really need to look at these very frequent events.
Yeah. All injuries are not created equal. We have limited organizational resources that we can use to attack carefully selected targets. There's a limit to how much an organization can tackle at once. We have a leadership obligation to go for the big guys first, to have the maximum impact for the most patients in terms of their outcomes. I'll honestly tell you, I get really frustrated by this. I see national initiatives that attack relatively unimportant problems. Well, maybe they're important, but where we have relatively poor science, we don't know how to fix it yet, you see, while they ignore big guys with huge opportunity. At Intermountain, we took adverse drug events down by more than 60% through a series of system fixes. In our initial trial, published way back in 1992 in New England Journal of Medicine, we reduced postoperative deep wound infection rates from 1.8%, with a research quality tracking system, by the way, to 0.4%. Saved our system $3.5 million at the time, but it showed up in real patient lives, you see. Those old standards that we used to accept about good behavior compared to our peers, don't trust them. They're not reliable. If anything, it's damned by faint praise. The last thing you want is to be at the average of your colleagues. Only compare yourself to theoretic perfect. Look where you have good science for change. Look where you have leadership and data. Set careful priorities and then demand real results.
Surgical site infections are really a great area to show the kind of integrated impact that we can have on reducing harm. Give us your take on surgical site infections.
There's a process for them that can massively reduce the rate of surgical site infections. It starts, of course, with proper patient preparation. I have to get hair away from the surgical site. I have to kill bacteria on the skin in general. The second major step, antibiotic prophylaxis. I'd like to have antibiotics in the circulation at maximal levels at the highest risk, at the moment of the greatest risk, when the knife goes through the skin. It turns out is the highest risk for that occurring. So that talks about timing of prophylactic antibiotics. I need good technique in surgery, sterile technique in surgery. It turns out to be absolutely critical. There's, of course, post-op wound care. Then there are a series of other, I regard them as secondary, but still quite important to a total program. Normothermia, for example, blood sugar levels play an important role. When you see the whole package with a competent team, you see much lower surgical infection rates than you see outside of that kind of a circumstance. We haven't achieved zero, but we've come a whole lot closer. Now, the second thing, within Intermountain, we believe that the cost of a deep or organ space wound infection is about $35,000, is our current best estimate. I know some others come up with different estimates for the same injury. They are massively expensive.
Break down that cost for us.
In breaking down the cost of a wound infection, we need to think of it in two different ways. The first is the actual site of infection. If you focus mostly, let's say, on abdominal infections, they're relatively inexpensive. Throw in a few deep mediastinal wound infections around a patient's heart following some sort of open heart procedure. Massively expensive, hundreds of thousands of dollars, multiple stays in an ICU, real risk of death, you see. I believe that's why our numbers are higher than some other programs. It's your choice of specific case types. So when I say $35,000 per infection, I mean across a full range of case types in a broadly based system, not some specific sub-selection within it. The second thing, think of the elements that actually drive the cost. Patient's going to be in the hospital additional days. You'll have a full course of antibiotic treatments associated with it. You'll have wound dressings, probably some sort of a vacuum system to close the wound. You might have reoperations to clean a wound. The costs mount up surprisingly rapidly, but when you think about it, there's no surprises here. These things are expensive. Now, the big lie. Under current payment systems, I'm often paid more when my patient gets the infection. I've actually had hospital administrators attempt to argue with me, saying, you know, you're reducing our revenues. After we deal with the morals of that little statement, we come back and talk about the true revenues. If you carefully examine daily margins, of course these guys are accountable for net operating income, daily margins, you'll discover that you're sometimes making small margins each day of care. Then you compare to how much you could make with that same bed, that same fixed resource, if you filled it with a patient with a legitimate need. With real surgery, for example, and you discover that the margins are this big as opposed to that big, if not negative. You see, any sophisticated CFO should understand that even under current payment mechanisms, there is no financial justification to tolerate those injury rates. You're damaging your organization financially. If you don't understand that, you need to learn it on behalf of your organization. If you can't learn it, your board needs to hold you accountable to it.
So often in our research test bed, we have hospitals out at the front line say, yes, but Dr. Denham, we're not Intermountain Healthcare, we're not Mayo Clinic, we're not Cleveland Clinic, we're not Vanderbilt, we're not the Brigham. We're facing different barriers and challenges. What take do you have on that?
You know, my only answer when people tell me we're not Intermountain, either am I. When we started this 15, 20 years ago, we didn't have any of these systems in place, but we had a vision and we had some leadership. And we knew that it was possible to be better. And we built it one step at a time. Now, what's your story going to be in 10 years? Are you going to be able to say that you had a similar vision, you had similar leadership, and one step at a time you started to build into the system that you could be, as opposed to the system that you are today? Nobody's that system when we start. That's why we need leadership.
After a very serious, unintentional adverse event, the fog of war sets in. and the processes of disclosure and care of the caregiver both sometimes are left behind because we're preserving the potential sustainability of an organization and the financial risks that could come from malpractice. Can you address this disclosure and care of the caregiver in the fog of war after a bad event?
This is a personal belief on my part, all right? I'm not speaking for Intermountain particularly, although I think I would be for most of my colleagues. Over the years, after carefully examining the evidence, I've become convinced that the best way to ensure organizational survival in the long haul is to be completely open and honest. Most malpractice events are stochastic, they're random. It's roll of the dice in some very real sense. The organizations that tend to do better over time are those who choose disclosure, honesty, improvement, over those who try to stonewall the public, you see, to protect their organization as they see it. It's the worst thing you can do. I can't count the patients that I've talked to who've had one of these nasty things happen to them. It's terrible. They've been hurt, harmed, their loved one is dead, usually. They're trying to get some sort of meaning to it. What if the meaning you gave them was to make it better for the next patient? You know, when you stonewall, when you go defensive, when you bring in the attorneys, very often they have two reactions. The first is they've hurt me, I'll hurt them back because they're jerks. The second is that the only way that I can give meaning to the loss of my loved one is to make sure it doesn't happen in the future. And the first step in making that happen is to bring these people to, well, recognize their own truth, bring them out of denial, if you will. Well, don't go that route. Don't go into denial. Make them a collaborator. Give some meaning to their loss. Turn that grief into something better for the next time around. Do the same thing for your people at the front line. Their hearts will be harmed very often. They come in to do good every day, and it's amazingly hurtful when this happens. You're struggling with it, you're trying to deal with it. Give them a road ahead. Isn't that a road for leadership? Isn't that what it means to see that distant vision of what we could be? To help people move beyond that? Be a leader.
Brent, isn't risk management in today's typical frontline hospital more management of potential malpractice cases and not really risk management of future preventative activities?
Yeah, risk management. Which risk? A risk of a lawsuit or a risk of harm to patients, you see? One of the things you learn as you study this over time is that it's all about relationships, and that in a very real sense, the legal risk is stochastic, is the term that we use. It means random. It has a very strong component of randomness to it. Your belief that you can manage legal risk through these sorts of approaches, if you believe that, you need to examine it very, very closely. It does not match the evidence of what we know about this particular field. Imagine that as a leader, you shifted the focus to reducing injury rates. Imagine that you involved all who were harmed by such an event, not just the patient's family, but also the caregivers, in finding a way to make it better next time. Imagine that you gave meaning to their experience. Oh, empirically, organizations that have done that have seen a major drop in their malpractice risk. That's where the truth lies. That's your job as a leader, to see that truth, to share it in a forceful way, and set a new way ahead. I think that's where success in the next generation is going to happen.
Brent, we've come to the conclusion that ground zero in the war on healthcare harm is not at the bedside. It's in the boardroom. Do you believe that?
Almost 15 years ago, a key researcher in patient safety, Dr. Scott Evans, did a seminal study. We were tracking the most common source of patient injury, adverse drug events, drug overdoses, allergic reactions, drug-drug interactions. In parallel to a state-of-the-art tracking system for those events, Scott was also tracking human error. We ran 8 years of data, over 200,000 consecutive inpatients at our flagship LDS hospital. We found almost 4,000 patient injuries. we found just over 4,100 human errors. Oh, the fascinating thing, 138 of the patient injuries tracked back to a human error. That's 3.5%. 96.5% of the patient injuries tracked back to a systems failure. Other studies have shown the same thing. Usually less than 5% of actual patient injuries will track back to the humans. It disturbs me. We keep talking about error. That term doesn't belong in a safe organization's vocabulary. Well, it does, but just as a small thing off to the side, you see. They're still important. They're just not very important compared to the big opportunity. Who controls those systems? I guarantee it's not the physicians and nurses at the bedside. That starts in the boardroom. That starts with the senior leadership. Again, my role at Intermountain is to make it easy to do it right. I control those systems. I build the circumstances where my colleagues can be all that they ever wanted to be. In terms of the practice of medicine, the practice of nursing, the practice of pharmacy, on behalf of the people who seek our help in their hour of greatest need, usually. And that's the promise we make, that team with that vision can create a new healthcare system that does massively better than we experience today.
Brent, you have been a center for real innovation in the care delivery, performance improvement. What can we hope for in technologies in the future?
Healthcare is on the verge of major breakthroughs, not in new biomedical advances so much as in the context of how we deliver care. For example, I'm working on a new electronic medical record system. We already have a state-of-the-art system that competes well with any system available today. We're creating the system for the next generation. The system that focuses primarily on supporting bedside care management with ideal data. Doing documentation as a secondary effect. That's a real game changer. You're going to see a completely new world when those kinds of systems pull in place and become available for widespread use. It goes a level deeper. Our ability to understand the sources of patient injury, in the broadest sense of that term, advancing day by day, year by year, immeasurably. We have not yet begun to understand how good we can be. And there's the excitement of being in this field at this time, isn't it? Some organizations are going to lead that. They're going to figure it out. They will create a new world. Some will fail. Some will just follow. We want to be a leader.
We've been pretty arrogant in healthcare, believing that we really have a handle on all innovation. And it's pretty shocking how much we can learn from other industries. Is that a fair statement?
We are not alone. When you carefully study this field, you understand that many other industries have faced similar challenges. Now, arguably, healthcare delivery is one of the most complex undertakings that human beings have ever attempted. That said, we have a massive body of science and experience about what happens when well-meaning, highly trained, very smart human beings interact with complex systems. We've discovered that you can anticipate the inevitable failures, and studying the patterns of those failures, you can build systems that, again, make it easier to do it right. I would strongly recommend a close look at the Nuclear Regulatory Commission. Great lessons there. Oh, aircraft carriers. Very high-risk enterprise that deserves careful study. National Transportation Safety Board, the reason that it's safe to step on an airplane, as I will do in a few hours to fly home, for example. The list goes on. Wonderful lessons. They will have to be translated into healthcare. Why would we cut new ground when the gems are there for the taking?